I'd like to begin this podcast by acknowledging the Yagara and the Turrbal people as the traditional custodians of Meanjin, the lands on which our podcast is recorded. We pay our respects to elders past, present, and emerging. Hello, Academy Associates. Thanks for choosing to listen to the BodyTrack Academy podcasts, where our aim is to bring clinical research to real-life clinical practice. For further learning opportunities, why not access our educational webinars? To access these, click on the link in the show notes. To further keep up to date with what we offer, why not join our Academy mailing list where you'll receive exclusive content, discounts on webinars, and more. Again, you'll find a link in the show notes.
Well, welcome back to part 2. So Caitlin's still here, and we're going to be talking about hip osteoarthritis. So pretty common condition, very common self-diagnosed. We have a lot of clients come in and tell us they have it, but something that in the EP world we get referred for from doctors, we get referred for from physios. We see it, people report it. It can be pretty easy to identify in terms of symptoms and what people report to us. But over to you, Caitlin. Tell us a little bit more about hip osteoarthritis.
So hip osteoarthritis are very similar to knee osteoarthritis with regards to what's actually happening within the joint itself. So it's a degenerative joint disease. It affects the articular cartilage and the surrounding tissues. And we consider hip osteoarthritis as primary or secondary. So primary, there's no known cause. It's often associated with people who have multiple joints affected with osteoarthritis, and it's associated with aging. And then we have secondary. So secondary osteoarthritis may be associated with trauma or other disorders similar to FAI. So we know that FAI, especially can morphologies, can increase the likelihood of getting osteoarthritis. So within the community, 9.2% of adults greater than 45 years old are quite symptomatic, and we see it a lot in women post-menopause, which again makes sense when we have a think about what metabolic changes are happening through menopause. But what we also see with it is that it can be identified with other chronic conditions as well. So hip osteoarthritis can have an increased risk of cardiovascular diseases, which when we put the pieces of the puzzle together, that makes sense. You've got hip osteoarthritis, you've got reduced range of movement, you've got stiffness in the morning. It may be painful. You don't want to exercise as much. We can see the flow-on effect from there.
So building on that, I know we spoke about this in our knee podcast, but language around talking to clients like this, and it's a massive thing. And I think sometimes people sort of take it as a bit of a label. Oh, I've got this degenerative wear and tear. How are you educating your clients on what this is and what actually is going on?
So what I educate my patients is it's age-related changes. So it is something that is quite common. It's something that happens associated with aging. And what's really important is that we can still continue to maintain functionality with it. And what's really important is when I have patients come in to see me is I'm identifying what their limitations are with the hip from a range of movement perspective, and really show them how they can continue to be functional. So it's about educating that walking is not going to be causing further changes within the hip. Strengthening is not going to be causing further changes. And there's even been some studies showing that running does not increase the risk of osteoarthritis or further degeneration associated with osteoarthritis. So it's about empowering the individual going, okay, you've got this. Similar to how you might have osteoarthritis within your spine or within your finger. You can still be functional with it. So it's about empowering the individuals around it and showing them and educating them that the only time when you want to be cautious is if you're overloading and causing pain.
Yeah.
Hip osteoarthritis will be stiff, but we shouldn't have extensive pain.
Yeah, it's a good point to note, especially when it comes around running and as the research progresses. It's pretty common that we'll have someone come in, I used to do a lot of running, I used to play a lot of this, play a lot of that. Now I've got hip arthritis. Previous injury, so really important to screen for. Like what we spoke about, can be that secondary if they've had any traumatic hip injuries, things like that. But again, sort of education that it is normal. And if we look at that client's hip on a scan, they could have the exact same hip as me and I could have no pain at all. So really hammering home that, it's not what's going on at the joint, it's what's around it. And we need to keep the joint strong, healthy, and mobile. Excellent. So moving around from diagnosis, I think we probably see this one as a scan more than anything. Probably in our context, we'll have someone who has gone to the GP with hip pain, they've been scanned, they've got osteoarthritis. What are some other diagnostic tools you're looking at? And what are some of the symptoms that they report to us?
So from a physio perspective, we will often diagnose hip osteoarthritis without needing to have imaging with it, because we're actually having a look at what's associated with the movement. So symptoms similar to knee osteoarthritis, so they have pain around the hip joint that's actually more commonly the groin with it. It can be gradual or it can be a sudden onset of pain. And again, remembering, is it the hip osteoarthritis that's actually like the changes within the hip, the changes with the vascularity? Is that the source of pain, or is it actually the structures around the hip that are becoming painful? So that's really important to be educating with. Stiffness of the morning, again, similar to knee osteoarthritis, but also stiffness with sitting. And we have to think about the hip position that a lot of people are in when they're sitting. And what they will find is that they get increased pain or stiffness overnight as well. Like osteoarthritis, it improves with activity. So these are all the little things that clients are going to be telling you. They may get some locking or sticking, especially if they've been sitting in like a bucket seat in a car, or they've been to the theatre and they're in a really deep chair. They might say, oh, I sort of got to stand and wait a minute before I get moving because it feels like my hip is stuck with it. And also crectus will be something we hear with it. So from a diagnostic perspective, what we see is a little bit of more global loss of range of movement. So they'll have hip pain, loss of hip internal rotation, and a loss of hip flexion as well. But what we will also see is they will start to lose some hip extension and hip external rotation. So as compared to FAI, where it's associated with the morphology of the bone that's limiting a range of movement, we're getting degenerative changes within the whole joint itself. So we look for hip flexion and internal rotation, but we're also having a look at, well, what's happening in the hip extension position as well. There is some other criteria that you can have a think about that doesn't need imaging. So hip pain with hip internal rotation, and morning stiffness longer than 60 minutes in a population over the age of 50. You might be thinking that's a little bit of hip osteoarthritis. And then you can get some imaging done and also some blood testing done, but you give a bit more information as well.
Excellent. And from your practice, I know we spoke about more that functional perspective. Would you do a bit of a global range of motion around the hip? Is that pretty standard for you when assessing someone with hip OA?
So when I'm trying to distinguish does an individual have hip OA or FAI, I'm having a look at some combined movements. So I'm looking at hip flexion. I'm having a look at internal rotation, external rotation. What are they like with hip flexion and internal rotation? What are they like in extension, doing internal rotation and external rotation? So I want to see the features I'm linking together as well. I'm also going to be, again, something that we do as clinicians, actually feeling how the joint is moving. Am I getting a lot of body blocks, or am I getting a joint spasm? Depends at what point the patient's coming in. What are their compensatory factors? If I get them sitting, so this is a really easy one to do. Get a patient to sit and ask them to lift their knee up. Can they lift their knee up, or do they move their leg out to the side, or do they go into a posterior pelvic tilt and flex through the lumbar spine? Correct that. Can they lift their hip up? No. Why not? Oh, it just feels stuck. That gives you it's a really, really simple test that gives you a lot of information.
I was also going to ask range of motion.
Mm-hmm.
Obviously, we spoke about last time, okay, we want to compare sides, affected versus non-affected. What's a normal hip internal external range of motion look like?
So
very individualized.
Very
and
individual.
I've been taught a few different things. One of those, total range of motion, 90 degrees.
Right. So that's an important one, because if you're having a look at hip range of movement, and if someone might be anteverted or retroverted, so where they've actually got change within the femoral position, if you've got a combined 90, that makes you think, okay, it's not necessarily osteoarthritic, it's not necessarily FAI. I've got an individual that actually has a change within the morphology of the hip. What we want to think about from a hip internal rotation perspective, we're looking at 30 to 40 degrees comparative on each side. Then from external rotation, we expect a little bit more range of movement. So we're looking at 40 to 60. So that combined 90, really, really good to have a look at. But if you want to get a little bit more specific, going, okay, what am I like each side? Am I within my parameters, or have I got 15 degrees on one side and 35 on the other?
Yeah, it can be very different. I think we see that in different populations as well. From my experience in seeing people do like martial arts, you usually have a ridiculous amount of external rotation from lifting the hips up and quite limited internal rotation. So yeah, really good point on checking total range of motion. Perfect. And moving on, in terms of our symptoms, commonly seen with like end range of motion with pain in the groin. So one of the common ones that I'd probably see in clinic is, say you've got a client and they're just doing a glute stretch, but they feel it in the groin. So in through flexion, would we see that with extension, abduction, any sort of end range?
Yeah. So you're expecting that they're going to feel more of use the term impingement, or more of a blocking rather than a stretch.
Yeah.
It'll be, I just can't move any further. Okay. Let's try and change a bit with different position. You get them out of that end range position. Oh, okay, now I can feel a stretch. So that gives you a lot of useful information.
And moving on to our management phase, one of the questions I had for you was penile osteo. Commonly prescribed, commonly used regularly by a lot of clients that come in through the clinic. Do we have any updated guidelines? How long should we be using this? Is this something we should be using? Should we encourage our clients to come off it if they need to?
So when it comes to medication, it's a really fine line from an education perspective. So if a patient has chosen to go on Panadol osteo themselves, it's about reinforcing, making sure that they're using it within the prescription guidelines. So as a physio, I can't prescribe medication. So it's about educating, are you using it? If it's 2 tablets 3 times a day, are you using that? Is that effective? Do we need to change that? So I've got some patients that have their 2 Panadol osteo 3 days a week. They're 75. They've been doing that for the past 5 years. They're getting screened by their GP. They're not having any changes for them. It keeps them functional. It keeps them moving. So to answer your question with it really depends on the individual. So if someone's having an acute flare and Panadol osteo is effective in reducing their pain behaviours, normally it improves their function, then it's about having that conversation with them around, okay, how long have you been on your Panadol osteo for? Do you normally take your Panadol osteo? What happens when you don't take it? And you might find that they go, oh, if I miss it, it really spikes my pain. So I no longer really look at how quickly do I need to take someone off their pain medication, but if they're starting to feel a bit better, I do have that conversation with them going, what happens if you don't take the Panadol osteo? So there's no guidelines as such that we follow outside of the prescription guideline, but it's often something if they're feeling like they need to be on consistently or they have been taking consistently, I get them to check with their GP to make sure that they're still having really good liver function, with it, they're still having good kidney function. There's no other concerns that they're having with it.
Excellent. Moving on to a little bit more of the management strategies. One thing that we both sort of listed here was our water-based exercises, something that's very, very therapeutic. I think, as we know, it's great for decreasing pain, probably improving a bit of pain-free range. Some elements of strengthening. What sort of your views in terms of strengthening of water-based land? Are we preferencing land-based loading because it's more specific to what they need to be doing? Would you see aqua as more of a therapeutic approach?
I always educate my patients that I encourage them to do aqua if it's something they like doing. because it's, as all those things you said, it's reduced load. You've got a little bit of that hydrostatic pressure, so they feel supported in the water. They can move more comfortably through range, but I really reinforce to them that it does not replace land-based activities. Yes, you can get some really nice strengthening. Yes, it's really nice if you're having an acute flare-up, but all those things you said, it does not replicate what we need to do on land. But what I do tell them is that sometimes they might find they can push themselves a little bit harder at aqua, and that we just need to be a little bit lighter with the land-based activities, so keeping it individualised. If I've got a patient who says, I hate getting in the water, I don't want to do hydro, we focus on land-based activities. So I'm for it, but also re-educating that it's not land, it's not water, and
Yeah.
it's got to be done.
Yeah. Can be very good complementary.
Absolutely.
Yeah.
Hey, thanks for taking the time to listen to our podcast, and we hope you're learning a lot in this particular episode. Just a shout out to our sponsor, HGG Performance, which provide very high quality, innovative gym equipment and custom fit outs to enable you to pivot your potential and smash your performance and rehab goals. They are world renowned for their innovative creations in the gym accessory space, including the best selling ISO Tib LT, Tib Bar, Wrist Axe, and Nordic Bar. And I got to say, we're using some of these equipment in our clinic and finding some great results. Used by professional sports teams, athletes, and coaches worldwide, as well as the military, health practitioners, and apparently even Joe Rogan uses their gear. HGG is a proudly Aussie-owned company that makes all their gym equipment at their Gold Coast HQ. And our partnership with them, we are stoked to offer you 10% discount on any product with the code BodyTrack10, so you can experience what all the hype is about yourself. So jump over to their website, go to the checkout, punch in the code of BodyTrack10 to get 10% off on any of their great innovative gym equipment, and start using today. Thanks very much.
And then the other big one was our risk factor modification, weight. What can you tell us about the weight?
So we see with the evidence of low back pain, with knee osteoarthritis, with hip osteoarthritis, that weight management, so the less weight that we are carrying, the less forces that are going through the joints. So it's about, especially with something around hip osteoarthritis, what is a client or a patient comfortable doing to help with their weight management? So we know diet has an important factor with it, and often I'll ask them, have they engaged with a nutritionist to help with that strategies, especially a little bit older, especially menopausal women, to make sure that they're eating the right things, but also then getting an understanding of, well, what are your current activity levels at the moment? If they're like, oh, I don't know what to do, I'm not sure what I enjoy, we have the discussion around weight management, but actually try and increase the exercise tolerance first with it as well. So it's a discussion, but I also recognise that for some people, especially when this is something that's been building up for a little while, it's a really tough thing for them to try to change.
Yeah, definitely. And I think we see a lot in the EP world of people come in, I've got OA, I need to lose 10 kilos. It's sort of like, how do we frame that? Is it, okay, let's educate this client on this is how you lose weight, this is what you do? Or do we start with, okay, let's actually get you doing the program, let's start you moving, and then start to progress towards that, and sort of picking and choosing where your client's at, what they're capable with to push into that. Because indirectly, if we're starting an exercise program, we're going to get positive changes in or body composition. So,
and I think that's a really important factor to educate an individual as well, is that once you start doing strength training, your weight may not change, but your muscle mass is.
yes.
So you have got increased capacity for your joint and the load that's going through it. So for some people, when it's that, they're saying, oh, I just want to lose 10 kilos, the focus on getting exercise and actually changing muscle mass, I educate them that they're not always going to see a change on the scale. But what they are going to feel is that they move freer. They want to go out and exercise. They want to do their program. For me, that's a little bigger as well. So I guess we've just got to make sure what's the individual in front of us, and is losing that 10 kilos really going to be effective for them? Or is it the individual that needs to lose 40 to 50 kilos that it's going to?
Yeah, definitely. And from our end, if we're looking at body composition, We're lucky enough to have the BIA scales here. They're not entirely accurate, but if we reproduce the same testing conditions, we can see changes. But probably educating if they are beginning to engage in a resistance-based program and they're not really doing much cardiovascular exercise, looking at something like a waist or a hip circumference is going to be a lot better, and probably educating that client, hey, the scales aren't indicative of your health, essentially. So, we'll come back because we're both on the conservative treatment side for the main part, but we'll just quickly have a chat about sort of surgery and hip replacement, which is, I guess, the end game of the hip arthritis. Mainly doing the anterior and the posterior. So for the listeners, the anterior, usually less invasive, going in through the front of the hip, but moving things out of the way, not cutting into them. And then for the posterior, going straight through glute max, glute med as well.
So things have actually changed.
They have.
Yeah.
There you go. This
So-
is perfect.
As all things, like we spoke a little bit with the knee osteoarthritis, the more information we have as technology changes, we're actually seeing some changes with how hip replacements are happening. So we do see the anterior and posterior approaches, but what they're actually trying to change is what's the least invasive and how can we not affect as much of the musculature around the hip. So a lot of the posterior approaches now, you won't actually see them affect the gluteal muscles with it. So that's a real important one for people who are having hip replacements, or EPs, physios who are managing people post hip replacement. What approach, but what's actually been affected with the approach. So having the surgical notes will actually let you know where they actually cut through with the approaches from there. The management post with regards to restrictions in hip range is all about making sure that the actual replacement doesn't dislocate until the trauma to the area settles down. So, and that's normally 8 to 12 weeks, depending on the surgeon, what the post-op protocols are with it. So when we're having a look at individuals for hip replacement, so one of the key things leading into hip replacement, similar to knee osteoarthritis, what's the range of movement like? What's affecting? What's their function like? What's their night pain like? And again, we don't try to say, oh, wait until the last minute. It's now, are you in the best position to manage the hip replacement?
Yeah, excellent.
With it. So yeah, it's really interesting. There's some lateral approaches now as well for a hip replacement. So yeah, it's as an EP, I encourage to ask the question of the patient if they don't know, get them to ask their GP, their physio, their surgeon, what approach was done, and if there wasn't any musculature that was affected with it, because you'll actually see some really good changes with the way that they rehab. We're seeing some really nice rehab of hip replacements now. Not as many complications, function returning quite quickly too.
Yeah, excellent. And from sort of our perspective, we spoke a little bit about it last time, but in terms of clients seeing orthopedic surgeons, it basically comes down to the point of, can you live with the condition of your hip, and what have you done to treat it, essentially. Had a statistic here that exercise can reduce the need for a joint replacement by 44%. For up to 6 years in hip OA. So really good stat to throw out there if you're trying to educate someone and get them on board with some sort of conservative management or some sort of strength training. If we are seeing a client who's got hip OA, let's say they're in that sort of moderate category, moderate symptoms, should we be educating them on how long we should be intervening for conservatively if they were leaning towards the hip replacement approach?
So having that education of, well, what's the main limitation with it? Is it strength that's limiting, or is it range of movement? So if it's range of movement, that's their main limitation, then it's about the education of, okay, let's keep building your strength within the range of movement you've got. As your range of movement changes, that might be the precursor to them. So there might be someone that goes 6 months to see. If you've got an individual that has not a lot of strength and not a lot of range of movement, it may simply be going, we're going to trial 3 to 6 months. We'll see what changes we can create. If we're getting improved strength, but your range of movement's continuing to decrease, then that might be a sign where you're really going, This might be someone that may need a hip replacement sooner, but what you're doing is you're prehabbing them. So you're building that foundational strength, neuromuscular control, stability within the range that they've got to have a better outcome post-operatively as well. So that's the other way you can have a look at the individual going, don't give up on this. We're going to do 3 months. We'll see what changes. If you end up having a hip replacement, you've actually put yourself in a better position because you now know what exercises you're going to be doing post-operatively as well.
Yeah, excellent. I think it's definitely a question that we get a lot of, how long does this take? Usually, as a rule of thumb, I say 12 weeks of consistent to see a change. And that change may not be, all right, cool, you can go run up the stairs now. It could be, now you can get out of your car pain-free or something like that. Definitely encourage people that if they are sort of giving their recommendations and timelines, doing that after you've done an assessment. Because you want to see how the client's moving, what they're capable of. Could be as simple as, where does their sit-to-stand normative data sit? Are they at the low end? Cool. I want to see you get to the average for your age category. Is that similar stuff that you'd be adding on and probably educating towards the end of the session and then looping back?
Absolutely. So trying really hard when initially talking to an individual, getting their history, doing an assessment, is to not, oh, you've got reduced hip range of movement, you must be going towards hip replacement. It's really important with the language that you get all the information together and educate at the end. Otherwise, you might be leading yourself down a rabbit hole that you don't need to go down, or you might be educating on something that isn't actually warranted to the individual that's in front of you. You're talking about getting in and out of the car. Another really simple one that a lot of patients will say is, I struggle to put my shoes and socks on. I struggle to put my underwear on. So there's some really easy ones that you can talk to an individual and get as a measurable going, okay, in 3 months, let's have a conversation of, how do you find taking your shoes and socks off? How do you find putting your underwear on in the morning? And how do you find getting in and out of the car?
Yeah.
So it's really good to have the measurables in clinic going. Your sit-to-stands improves, your capacity to do hip extension has improved. How do you feel with the functionals? It's still really hard for me to put my shoes and socks on, which is really frustrating. I have to get my wife to put my socks on now in the morning. Cool. Functionally, you've improved in clinic with what we're measuring, but what you're telling me from an activities of daily living is you're not changing. What's more important?
Yeah, perfect. Really good point. So I guess coming along in terms of our conservative approach and exercise management, where does manual therapy and a bit hands-on therapy sit in this realm?
Excellent question.
Thank you.
It, again, depends on the individual. So I've got some really nice strategies that I'll use with hip osteoarthritic patients that I have coming. So we've got some really nice traction techniques that we can do with the belt around the hip that can be pain modulating for a patient. So they're actually ones that individuals can do themselves. They're really nice ones that I've seen EPs do before as well with bands, about being able to get someone into a hip flexion and either doing a lateral distraction, or it's actually a little bit harder to do a different sort of distraction, but even a posterior distraction can actually help them feel like they've got a little bit more movement within the joint themselves, and even down regulatory techniques. So often glutes, if they've been told, oh, you've got to work your glutes, you've got to work your glutes, and they haven't had as much functional capacity with that, down regulation through the soft tissues can be really effective too. So they're definitely patients that I do that in clinic. They're the ones that often say, oh, this feels great. It helps me be able to continue to participate in EP, continue with my walking capacity. So there is a role for manual therapy, but it really is individualized. Again, I've got some patients that are like, no, I don't really feel like I need it, but it depends on what you see. If I've got an individual come in, their hip range of movement, thinking of a lovely lady I treat at the moment, normally 90, 95. If she's coming in and she's getting about 80, 85, and she's like, okay, when I haven't been exercising as much, the cold weather's getting to me, I'm doing a lot more sitting for X, Y, and Z, and my hips really sore. Often doing that distraction technique and that down regulation has a really positive response to her, because she can then go away and maintain all her exercises and functionality.
And in terms of our banded distraction work, is the theory behind that where essentially calling the joint into a little bit more congruency. Is that the theory behind it? That we can put stretch on the muscles without, let's say, like sort of impinging or translating through the joint?
I think the terminology we need to think about, it's more down regulation. So is it stretching the joint capsule? Is it stretching the posterior or the lateral structures? Is it actually changing the joint congruency? We don't know. What's more important is it causing pain? No. Is it in an end of brain activating position? No. Are they feeling better afterwards? Yes. Awesome. This is the right sort of thing to use. So I think trying to change the language that we're doing, saying what we're doing is we're down regulating through the entire hip. It's helping you feel like you're getting better muscle activation. It's helping you feel like you're moving a little bit better, because we can't actually say this is what is happening. Similar with spinal mobilizations. Spinal mobilizations, once upon a time, they'll say, oh, you're getting this millimeter of difference. What we're now understanding is we're actually getting modulation. We're changing how your body's feeling. We're changing how your brain's interpreting the movement. We're changing general muscle capacity through there. We're not quite sure how 100% happens, but that's what's happening through there. So rather than getting the patient thinking, oh, I've really got to do this mobilization all the time because it's going to help keep stretching up my hip, it's about educating time and place when to do it.
Yeah, excellent. And I think something in terms of mobility we alluded to earlier, if you're getting end range motion where you're not actually feeling the stretch in the muscles that you want to, doing something like your banded distraction, having the option for manual therapy, but also doing some things like your foam rolling or your trigger ball release is actually a great way to go around that, because it's going to complement your strength work, and it's going to continue that client feeling a little bit more free and able. Definitely more so now in the EP space, they probably push away from the release work and the trigger ball work, which is great. And I think there's more ways to skin a cat, and you can do squats and stretch the muscles. It's going to be just as effective. But if you're looking at like a pain management strategy, having that up your sleeve is massive for clients. If they can do something to down regulate, and potentially if our exercises are, making things a little bit tired, a little bit sore, it's a really great way to balance or offset what you're doing. So,
and I think it's really important education. If every single morning your client has to trigger ball, has to stretch, and has to foam roll, they're not doing the right thing.
Yeah.
If it's, oh, I feel like it's a really nice recovery, the evening that I've done a strength session, or I like to do it as, if I'm getting into my squats, things aren't quite feeling 100%. I spend a couple of minutes on the trigger ball and the foam roller, and that helps me feel like I move a bit freer. Excellent. It's when it's an every single day thing that you go, this isn't actually doing what we think it's doing, and we need to think of what else is missing or what we're not doing right.
Yeah, excellent. Moving on to our exercise prescription. I know we're probably going to touch on it, but that global strength thing, it's probably something that I see getting missed a lot. There's always a big focus on glutes. Glute med, very important. Sideline hip abductions. A lot of muscle groups get missed. And especially looking above and below the area. We spoke about it in FAI, core control, hip flexor strength, hip adductor strength, ankle range of motion, dorsiflexion, ankle dorsiflexion. So the ability to pick up the toe, clear the floor. What are some other global movements you might be looking at with your clients with your hip arthritis?
Lumbar spine.
Yeah.
Huge lumbar spine control with it and movement. Because if you've got someone that's got hip osteoarthritis and poor lumbar spine flexion, they're going to be finding it really difficult to do a lot of things. So having a look at what are they actually training their lumbar spine? Can they do some 4-point kneeling work? Is that because in 4-point kneeling you can actually get out of a little bit of hip flexion too. So you can get a little bit better overall motor recruitment through there. Having a look at quads. Making sure that their overall globally got really good control through there. And even generalized hip movement. So are they able to do a simple exercise like a bent knee fall out? Can they control the movement? properly. So we often talk about really big strengthening work, but some simple control work can be really, really nice as well. And that not so much sideline abduction. Let's get the individual standing and moving.
In terms of some core-based exercises, would you be looking at starting someone with more of an isometric control so they can actually stabilize the trunk and target the hip? Would you be looking at some flexion extension? Is there any sort of order that you would approach these things?
No. Really depends on the individual, depends on the individual's age, depends on the individual's functionality, the individual's sport as well. So when I've got someone coming in and I'm having a look at globally what they're doing, it's not, all right, let's start with planks. It's going to be like, do we actually need to get you in 4-point in? Or do we actually need to get you in supine first? Do you need to do an isometric hip flexion with a little bit more focusing on that lumbar spine control? Or are you actually someone where we're going to do more targeted exercise? So I can't say that there's a particular way to do it. It really depends on the individual who comes in, which is what we should be doing. It's individualized, not here is the tip of the sheet of what I want you to do.
I think from my perspective, and I'm happy for you to go against this if you want to, but considering goals and individualization in terms of sometimes with OA, looking at hips and knees, the way that I like to structure my prescription is, okay, here's the hardest exercise you can do for the hip. So let's say it's a Bulgarian split squat, a lot of stability, or a single leg squat or something like that. Where's the client now? What are the steps that we can take towards that? That's something how I'll usually structure to grade, okay, where's someone at? What are the exercises they can do? What are they going to benefit from? What are your thoughts on that approach?
I think that can be a really smart way of thinking about it. And I guess that highlights one of the key things that we look at differently from physios compared to EPs, and highlights what we need to be working together in going, okay, your EPs don't have a look at from this perspective. I want to have a look at more specifically individual movement patterns, control in clinic through there. And that's then where that communication is important. So if I'm seeing a patient at hip OA, I don't think we have mutual hip OA, I say, okay, this is what I've assessed. These are the exercises that I'm giving them to do in their own time, focusing on X, Y, and Z. I'm happy for you to do a functional assessment and work towards key gym-based activities or other based activities within these limitations. And then from there, if you go, okay, Bulgarian split squat may be an achievable movement. Where are you at on that pillar? I've got no problems with that.
I think that's a really important part from collaboration perspective, that maybe the finer details that you give someone to work on don't restrict them from doing something else. And I think that's sometimes where we do get a mismatch with our physio and the EP, is that maybe a client might get prescribed a certain set of exercises and they're said they're not ready for anything beyond that. But when we're looking at, okay, what's the client doing outside of these exercises? Is he unpacking his garage or unpacking his truck or something like that? Complementing and making that really clear, I think, as we work together and saying, hey, these are the exercises I'm doing, this is where I'm going, does this align with your goals, and complementing them as well.
Absolutely. And I think it's really important with any collaboration, not just outside of hip osteoarthritis, is that you do have that communication, because some things a patient may or a client may tell me might be slightly different to the conversation that you have, and then going, okay, they've actually introduced this. What do you think? How can we, what's some parameters on how we can work around this? Because we want to be able to help the individual achieve their goals, and that's working together. And sometimes it might be, oh, no, can't do that because of X, Y, and Z. Oh, I didn't realize that. Great. So that's where that communication comes in. And I think it's really important that we highlight physios and EPs do different things, but we work really well together. And if we're not working well together, we're not doing our job.
Definitely.
Thanks for listening. We hope you enjoyed this podcast. So remember to share, like, or follow to keep updated with all our podcasts and educational resources.